Okay. So it's still us. We will have Shannon Ton from the Minnesota Board of Pharmacy talking about the prescription drug monitoring program and all the new things and all the things we're all supposed to do, or all of the things
are expected to do.
Yes. And this is going to be, of course, the 2-part series. We will have another one. I think it's in 2 weeks, correct? It's coming up.
All right. We got a lot of different things coming up. And I think that next one as well is going to be very interesting on psychedelic microdosing. I think that's something that it's interesting that I've had patients ask me about. And then back to gambling disorders in December. So a lot of great talks coming up.
And then, Shannon will come back in 3 weeks. And then we're going to take a little bit of a break over the holidays. And we have a special treat for you on the first Echo back in January. Still CME, you guys will get the, of course, thing to click on to get your credits. Turn your video on if you don't mind. Chat in questions. I know several of you have kind of mentioned that you don't have audio or video or whatever today. So don't hesitate to chat. We will facilitate those with Shannon at the end. And please let us know if there's more than one person in your room.
All right. Remember, if you need any help, please just give us a ring. You can reach out to Erin, our nurse, or you can give our cell phones a ring. We get a lot of great calls, and don't be afraid to call if you got a patient that's kind of, needing a little extra TLC.
There have been a lot of exciting patients in the state lately.
There have been.
Okay, online site, if you want to look at the other echoes, you want to get help, there's contact information for us there. You can see again the list of upcoming echoes, get copies of the old ones, all of the stuff.
And remember the Addiction Connection podcast, lots of different things. We have not gotten this week's out yet, but it will be soon. I believe it's going to be on prazosin and the use in alcohol use disorder, which is something kind of interesting. It's been around for a while, but there's been some new articles. So we're going to talk about that.
Yeah, and we're trying to, there's a couple new things kind of like that are up and coming, or big kind of things that have come to the forefront. We're trying to do the topics like those coming up. And if you guys have anything you're hearing or seeing or questions on, and you want us to do the research for you and podcast it, we would be more than willing. Okay, so Minnesota Board of Pharmacy, Shannon, are you if you want to share your own slide, Shannon, that'd be great. I can take ours down. What was the plan?
I can share my own slides.
Perfect.
Okay, let's see.
So if you want to give another intro of yourself, that would be great.
Yeah, don't be afraid to talk about yourself.
Tell us all.
Okay, I guess I will. I actually will talk a little bit about myself here. Just give me a thumbs up? Can everybody hear me okay? And my screen can be seen?
Looks perfect.
Okay, wonderful. Let me just get my screen up here. And we're good to go. So good afternoon. As said before, I'm Shannon from the Minnesota Board of Pharmacy. I've been here to present before under a different name. I was married in the last year. So I'm now Shannon Ton. And thanks for having me here again. It's always a pleasure. I think it's probably been 2 years since I've been here. So we have some new items to share, as well as the basic PMP information, what I like to call PMP 101. I have personally been with the PMP as the administrator for just over 6 years now. And before coming to the PMP, I worked in a large multi-specialty clinic, and really I talked to patients and providers like you all day long, and I really dealt with conflicts and issues. So I know what it's like to be on the front lines. Just haven't been there for a while. I also have no conflicts of interest to disclose, so we'll go ahead and proceed. Today, I'm going to talk about the Minnesota PMP and the changes that have taken place over time. You're going to have a better understanding of what information makes up the PMP database in Minnesota. And I'm going to provide information about who can access the Minnesota PMP database and when it is allowed per statute. We're going to talk about compliance with legislative requirements for healthcare providers that is related to the PMP. And finally, I'm going to show you how to access some helpful resources that are available on our website and within the PMP web portal. So going back to the creation of the Minnesota PMP, which was in January of 2010, we began collecting data. And in April of that same year, the PMP was open for account holders to access the data. Other big changes that have helped shape our program today, in 2014, the Minnesota legislature allowed the Minnesota PMP data to be shared with authorized users outside of Minnesota. This significantly enabled Minnesota users to also access other jurisdictions' patient history reports. And we'll talk about this in a bit more detail shortly. By July 1st of 2017, all licensed prescribers and pharmacists working in the state were required to register for and maintain a Minnesota PMP account. December 4th, 2018, big date for us, our program transitioned from our original software platform, which you may recall, it was called RX Sentry, to our new AWARE system. With this transition, we were able to secure funds for NARCS Care, which is the enhanced view of a patient history report that applies analytics and risk scores to the PMP data that you view. In August of 2020, the Board of Pharmacy secured funding to provide a statewide license to integrate access to view a patient's PMP report with one click from within an electronic health record or pharmacy dispensing software system. Integration, as we call it, prevents authorized account holders from leaving their clinical workflow to have to log in and access their patient's PMP data in a separate site. And just 2021 was the first requirement in PMP statute to have required review of a patient's history report prior to prescribing. One thing that has remained consistent since the Minnesota PMP was created in 2010 is Minnesota's intent of the collection of this data. The database is intended to promote public health and welfare, acting as a source of information for prescribers and pharmacists. It's also intended to act as an investigative tool for law enforcement and medical examiners. It's important to know that in Minnesota, the PMP is not intended to prevent people from obtaining needed drugs or to decrease the number of doses dispensed in the state. So our PMP in Minnesota resides within the Board of Pharmacy. Our program currently has a staff of 3, an administrator, that's me, a program coordinator, and a data analyst, plus our program director who oversees the Board of Pharmacy's controlled substance reporting section. And this section includes the PMP and our opiate product registration fee program, relatively new. There are currently over 30,000 active account holders, and in 2021, they searched the database over 4 million times. We're definitely on pace to exceed that. But to effectively utilize the PMP in Minnesota, it's important to know where the prescription data comes from. Pharmacies dispensing in Minnesota report Minnesota controlled substances scheduled 2 through 5, as well as all formulations of butalbital and gabapentin daily. Now, mail order pharmacies that are shipping into Minnesota are required to report those as well. Prescribers that dispense from their office for outpatient use must report these, but it does exclude veterinarians. Hospitals dispensing for outpatient use report these, though they do not report any medications that are administered inpatient. The VA and Indian Health Services are federal facilities, and they're not subject to state laws, but they do report their data to state PMPs. It's also important to know what is not reported to the PMP. So as I mentioned earlier, hospitals that dispense outpatient medications are required to report these when they're leaving the hospital with the patient, but any inpatient medications that are administered are not reported. Also, pharmacies that distribute drugs through the use of an automated drug distribution system machine do not report those dispensations to the PMP. These are generally found in like a nursing home or group home environment, and they dispense a dose at a time. There is one additional group of prescription data that has not been reported to the PMP, and that is the OTP data. Confidentiality laws that were written in the 70s and 80s intended to add additional layers of protections to those seeking substance abuse treatment. Those laws are still in effect today. Now, these same laws have historically prevented federally funded opioid treatment programs, or OTPs, from reporting their dispensations to state PMPs. Recently, for the first time in a long time, Health and Human Services had made some relatively significant changes to the confidentiality of SUD records. The changes allow OTPs to report to state PMPs, but they must have patient consent to do so. Now, there's a lot of barriers involved with this process. The first of which is obtaining consent from patients that have dealt with stigma attached to substance abuse. Also, technology changes required for these facilities to submit prescription data in the required format. And additionally, some of the medications, a great deal of the medications used for SUD treatment at these facilities are required to be administered at the facility, and these direct administration doses would not be required to be reported regardless. So how does the PMP data get from the prescription itself to you, the end user? A dispenser has 3 ways of reporting data to the PMP. Most of the larger pharmacy chains contract with a third-party uploader that will batch their daily dispensations at the end of the day. This batch is sent automatically by a secure file transfer. The pharmacy or uploader can also create a file and upload it directly to a web portal that's provided by our vendor just for receiving prescription data. This portal is called Clearinghouse. The third option, sometimes used by smaller pharmacies or providers that dispense from their offices, is manual entry. The user would log into their Clearinghouse account directly and complete a universal claim form with all the prescription data required to be reported. To be considered compliant, a pharmacy that's licensed to dispense prescriptions in Minnesota must report daily, either that business day or the following business day. If they dispensed no reportable prescriptions, they must submit a 0 report to indicate the null. Time frames greater than 1 day are not permitted. So each pharmacy should be accounted for by 28 to 31 reports per month, unless they're approved for a exemption from reporting. Exemptions must be requested by the pharmacy to the board, and they can be approved for one of the following reasons. Number 1, they're a registered OTP that's unable to report. Number 2, they only dispense inpatient prescriptions. Number 3, they are an automated drug distribution machine pharmacy, or their pharmacy never dispenses Minnesota-controlled substances into Minnesota. And again, if errors are contained in their submissions, the pharmacy is notified immediately, and they must resolve the errors within 7 days of the initial submission. So compliance. We feel that being within the Board of Pharmacy gives us an advantage to holding our pharmacies compliant with daily reporting, but compliance is an ongoing effort. It never stops, it's daily. Our program is dedicated to presenting to you as accurate and timely data as possible. To present like a visual timeline of the process of reporting a prescription to the Minnesota PMP, in this model, on Monday, which is day 1, the prescription is dispensed at the pharmacy. This is regardless of when the prescription was authorized or written by the prescriber. Data is reported based on dispensation or fill date. Either Monday or Tuesday, the prescription is sent to our vendor via the Clearinghouse web portal. There's also some pharmacy systems that submit data several times throughout the day, just of note. There is a delay while Clearinghouse assesses the file for errors. It does not go directly in. If the data passes the checks, it will load that same day or the next day. Any prescriptions that contain errors will be pulled out of that file and will not load. A notice will be sent to the pharmacy right away. A notice is sent every day until the errors are fixed. Now, in this example, the pharmacy is closed on Saturdays and Sundays, and the pharmacy is required to submit a separate 0 report for each day that they're closed, but they are allowed to submit these separate 0 reports on the next open business day. This would cause sometimes some delays when there's long weekends, especially like holiday long weekends. You can anticipate that there may be a day or two delay in the expectation of when you're going to see your prescription show up in there. And again, a note on errors. If the errors are outstanding for greater than 7 days, the pharmacy is considered non-compliant and they receive communication from our program during our monthly review process. The Minnesota PMP contracts with a vendor to collect and manage our database. And we've already talked about the way that prescription data is put into the PMP database, which is done through a data repository in our software system we've identified as clearinghouse. Access to the records is obtained through the other side, and this system is called AWARE. As prescribers, this is a system that you're probably more familiar with. So let's talk about access to the data for a minute. Minnesota Statute 152.126 allows access directly to the Minnesota PMP database to certain types of individuals. Prescribers and pharmacists that are licensed and practicing in the state are allowed access to assist with developing care plans for their patients. Also, to assist in identifying individuals that they're caring for that may be receiving controlled substances in a way that is inconsistent with recognized standards. Medical examiners and coroners are also allowed direct access account to assist in investigations on their decedents that are related to controlled substances. And in addition, within the Minnesota healthcare programs that manage individuals that are restricted to a single provider, pharmacy and hospital, accounts are available for managing compliance of those care plans. Now, each of these role types can also authorize a delegate or agent to search on their behalf. A delegate must create their own account, and access is approved by the prescriber, pharmacist, ME, or restricted recipient program director. The approving account holder is responsible for all searches performed by the delegate. There's also others who are allowed access to Minnesota PMP data. However, they must submit an appropriate request to our program staff, and the request is completed. The report is returned to the requester. Minnesota Health Licensing Board staff, they may submit a request for a licensee's controlled substance history if it's based on an open bona fide investigation of a complaint related to the licensee's controlled substance use or a possible controlled substance crime. They may also submit a request for a licensee's prescribing history based on, again, an open bona fide investigation of a complaint related to the licensee's prescribing history. Or they can request both if the complaint is related to both. An individual recipient of a controlled substance can submit a request for their own controlled substance history. Results can be sent to themselves or to a third party, but it must be submitted on a notarized form that we have available on our website. A member of local, state, or federal law enforcement can submit a request with a signed search warrant. None of these recipients are allowed direct access. Keep that in mind. Also, only Minnesota data is released. No other state data that direct access account holders may have access to can be released to these indirect access recipients. But for direct access users, as well as requests submitted to our program, the maximum prescription history returned for all requests is 12 months from the date requested. And that's regardless of what the signed search warrant says. Our program only retains for release at this time 12 months of data, and that's per statute. So Minnesota law is very specific about when access to PMP patient information is allowed. And I'll read the following is related to a prescriber of controlled substances in Minnesota. A prescriber or their authorized delegate may permissibly access PMP data for a current patient to whom the prescriber is prescribing or considering prescribing a controlled substance, providing emergency medical treatment for which access to the data may be necessary, providing care, and there is reason to believe based on a clinical indication that the patient may be abusing a controlled substance. Additionally, if they obtain patient consent, they can access the data when they're providing any other medical treatment for which the data may be necessary for a clinical purpose, and patient consent being the key phrase for that one. It's normal for us to get calls asking, can I use the PMP data for this? Or I'm wondering if this is included in permissible use. And I'll say we're very happy to provide general guidance, but we can't provide legal advice. And we do typically refer callers to bring their specific questions to their available legal or compliance resources when it's talking about interpretation of statute. So statute in Minnesota since 2014 allows PMP access connections with account holders in other states and jurisdictions. This connection is through a hub that allows data to be exchanged according to restrictions established by each individual state or jurisdiction. So a full map and list is always available on our website at any time. We keep that up to date of who you can access. The hub acts as a pass-through. So when a request comes in from an account holder passing from one state to the other, the hub checks authorization based on which state and what role type is requesting. These are all settings controlled by each state administrator. So states that Minnesota has agreements with can only access our data according to Minnesota restrictions. And likewise, Minnesota account holders have the ability to access PMP data in other states only according to their statutes. It's important to understand that most PMPs are fundamentally alike. However, there are differences from state to state. Without the ability to set these controls and specifications to match our legislative requirements, state to state searching would not be possible. Just a couple examples to put it in perspective. In some states, delegates are just not allowed to access their PMP data. Therefore, if we have a connection with them, our delegates just cannot search or receive results from that state. Also, Minnesota does not allow law enforcement direct access accounts. Our neighbors, Wisconsin, they do allow law enforcement agents to have direct access accounts. And when that law enforcement agent logs in, they do not have the option to receive responses from Minnesota data. And that's all configured in the data sharing hub. So Minnesota Statute 152.126 is completely dedicated to prescription monitoring program legislation, and it has 4 main requirements in it. We'll cover all 4 today, however, they may not all affect you. So initially in 2010, we began with the requirement to report controlled substances, and I've already covered that in some detail, so I'm not going to spend any more time on that. There is a requirement to register for and maintain an account. Then came the auditing requirements. And finally, we'll talk about required review of the PMP when prescribing opiates. So beginning July 1st, 2017, every prescriber licensed by a health-related licensing board practicing within the state who is authorized to prescribe controlled substances for humans and who holds a current registration issued by the Federal Drug Enforcement Administration, and every pharmacist licensed by the board and practicing within the state shall register and maintain a user account within the PMP. What does this entail? Registration for a web-based account. So you have to have a web-based account. And to maintain it, it needs to continually stay active, and that requires reviewing and validating your demographics annually. So annually, a window will pop up in your account. This will be prior to your 12-month account creation anniversary date. The window will present your demographic information as you entered it and request that you choose one of the following: everything's the same, skip and do later, or edit and save. You will receive an email 10 days prior to the due date, and another email will be sent 3 days prior if the validation was not yet completed. Your account will deactivate if this is not performed, and a call to the program will be required to reactivate it if it's not required. That's not too bad. We're pretty nice. We do it pretty quick. But you will be in a non-compliant status if your account is in an inactive status. So, and passwords expire every 180 days. Email reminders are sent, again, for password. An expired password will not deactivate your account, but you will be required to reset your password prior to your next login. So if you have not delegated authority to anyone to search on your behalf, you can tune out for this portion. No action is required at all if you don't have delegates. Delegates in Minnesota are not required to be licensed. So all delegate access to patient data is the responsibility of the supervising licensee that has approved the access. If a delegate has performed a search on your behalf at any time during the previous quarter, you are required to review the searches during the auditing period for that quarter. You'll receive a notification via email, and you will see a banner within your AWARE PMP account reminding you it's time to perform your audit or audits. The auditing module is now within delegate management, that portion of the AWARE account. Searches that require review will be presented for a brief review. It's very obvious which delegates have performed searches and what you need to review. If you find suspected impermissible access, we want you to remove access immediately and notify our program staff within 7 days. If a delegate is no longer working with you, we ask that you remove access within 3 days. And those are actually in statute. It's not just asking. But letting us know something like that, if you find something that you suspect to be permissible, just let us know what you think it is, and we can help you figure out what to do. There is another auditing requirement that began in 2019 at the same time as the delegate audit, but this is a requirement for the program staff, and we are required to select random account holders to perform self-audits on a portion of their patient searches, and this is, again, on a quarterly basis. I don't know how many of you have seen this before. It's usually a very small percentage that we do this, but we vary it a little bit. Our staff generates a random list of Minnesota PMP account holders of any role type. The only qualification to be selected is that the account holder performed at least one search themselves during the selected auditing period. A communication is sent to that account holder with instructions regarding the self-audit, and it includes this specific time period to audit, how to review, etc. With the form, an auditee can notify the program of any searches that may look unfamiliar. A form is sent, it's an electronic form that's sent along with the request to audit. And you don't have to fill out anything. It's all pre-filled for you. You're just letting us know that you performed the audit. Everything looks permissible, or some activity possibly could look that something may be impermissible. And that could be indicative of possibly your credentials being compromised or something else. But it's a good opportunity to take a look and let us know if something doesn't look right, and we can, again, help you work that out. If a selected auditee does not respond to the requested timeframe, their PMP account will be put into a limited access status until either the review is complete or communication has been received by our program staff. There is a point where these searches are no longer available for review. At that time, if the auditee is still in a delinquent status where they have not completed their audit, haven't let us know that they've completed their audit, they'll be referred to the respective licensing board for possibly disciplinary action. In the legislative session of 2019, required review of the PMP when prescribing was passed. So as of January 1st, 2021, a prescriber or agent of a prescriber, which is a delegate, must access the data before issuing an initial prescription for Schedule 2 through 4 opiates to their patient, and at least once every 3 months for patients receiving an opiate for chronic pain or participating in medication-assisted treatment for opiate addiction. However, there are 9 exceptions to these 2 requirements. Just to briefly go through them, the exceptions are related to palliative care, end-of-life care, care for the pain related to cancer or treatment of cancer, a prescription that's intended to last 5 days or less with no refills. A prescriber and patient have an ongoing or current relationship of a duration longer than 1 year. A prescription order that's issued within 14 days following surgery or 3 days after oral surgery. And it does need to follow the prescribing protocols established under the Opioid Prescribing Improvement Program. If it's a prescription that's administered to a patient who's admitted to an inpatient hospital, that's an exception. Also, if it's lawfully administered by injection or by any other means to the patient at the direction of a prescriber or pharmacist and in the presence of a prescriber or pharmacist. Or the final 2, if you are unable to access the data due to a medical emergency, it's not possible, or the data there's operational failure or other technical failure of our program. And in that case, we ask that you are required to report that failure to the board, and reporting the failure is simple as contacting the PMP help desk. At the end of this session, I'll show you an easy way to contact the help desk, and you can do this by phone or entering a ticket online. Please keep in mind that there are other entities that have regulations in place that require review of the Minnesota PMP that is outside of PMP statute. This includes the Support Act, as well as some regulations within the Opiate Prescribing Improvement Program. So those are outside of PMP statute. Now I'm just going to share with you a few initiatives that the Board of Pharmacy has invested in to aid prescribers. Historically, the PMP has done some small-scale notifications to prescribers and pharmacies regarding patients that have met certain thresholds related to multiple prescribers and multiple pharmacies in a set period of time. We called these controlled substance insight alerts. We've recently worked with our vendor to automate this type of notification and also enable 2 additional types of notification. The alert types are as seen here. You would get an alert if you prescribed for a patient that has a current opioid benzo overlap, if the patient's daily MME exceeds 91, and MME is morphine milligram equivalents, and or if you prescribed for a patient that has received prescriptions from 5 or more prescribers and 4 or more pharmacies in a 30-day period. Patient or clinical alerts, what we call them, are sent in 3 different ways. So when you first log into your PMP Aware account, the My Dashboard landing page will display, and you'll see any active patient alerts. This will show as new until viewed and remain in the dashboard or under patient alerts for 180 days. Clicking on the patient's name will generate the report, the patient report, and it will include the alert in there. Clicking on View All Patient Alerts will allow you to see a list of all alerts that you've received, including the type of alert, and they will remain there for 180 days. Additionally, once per month, account holders will receive an email with a notification that the alerts have triggered for their patients. The email will ask them to log in and view the alerts. This email will be sent on the 3rd Wednesday of each month, and you'll receive 1 email regardless of how many alerts are displayed in your account. So regardless of what patients you care for, you're not going to get a dump of emails. And finally, all account holders that access the patient NARCS care report, so searching your patient, will see a flag indicating the alert in the state indicators area of the risk indicators. This will also appear for 180 days after the alert triggers. Since these alerts are automated, we don't have the ability to disable alerts for care situations such as hospice, cancer care, or other situations where prescribing outside of these thresholds would be considered routine. The intent is to make providers aware of the potential risk when they may not otherwise be aware. If you receive an alert and are aware of the prescribing and dispensing and feel it's appropriate for your patient, we ask that you simply disregard the notification. Alerts are intended only to provide additional information to support your care decisions and are in no way to be considered an implication of wrongdoing on the part of the provider or the patient. In the future, we hope to be able to filter and adjust alert recipients based on prescriber specialty, possibly. So another tool that's sent on a quarterly basis is the Minnesota PMP Prescriber Report, not to be confused with the opioid prescribing reports that are sent annually by the Department of Human Services Opioid Prescribing Improvement Program. The prescriber reports do not require any action and are shared only with the prescriber themselves. They are intended, again, as informational only. To receive a PMP prescriber report, you must have an active Minnesota PMP account, have a defined specialty within your account, and have written at least 1 opioid, sedative, or stimulant prescription as reported to the PMP, Minnesota PMP, in the prior 6-month period. The report contains a summary of your prescribing as reported to the PMP and a comparison to your peers within the same specialty for the previous 6-month period. So for example, your Q3 prescriber report contains information for April 1st through September 30th. The specialty use is the one that you chose within your Minnesota PMP account. If you view your report and feel your peer comparison is not effective, you can easily change your specialty within your Aware account. However, you won't see your new comparison until your next quarter's PMP prescriber report. And again, like patient alerts, these reports are not intended to imply any wrongdoing and are shared only with the prescriber themselves. When you receive a PMP prescriber report, there's an email sent notifying you to log into your account and access the information. There's also a link to a user guide provided, which is also available within Aware under the Resources tab. Looking at a sample report, the header lists basic information, your name and DEA number associated with your PMP account. You can use the dropdowns to select which quarter's report you'd like to view. The specialty as selected by the prescriber at the time of registration is used for this comparison. If the number of peers in specialty level 3 is too small for a statistically valid comparison, specialty level 2 is used. Now, the selections for nurse practitioners and PAs are very limited in specialty. We recommend paying less attention to level 1 and pay more attention to level 2 and 3 when selecting your specialty, as these are the levels used for comparison, and really it's the only thing that this specialty is used for. So for example, a physician assistant working in orthopedic surgery would have a limited choice under PA as level 1. Most likely they would select physician assistant surgery. Rather, if searching the physician categories under level 1, they could search surgery, orthopedic surgery under physician, and they'll have a much more effective peer comparison with other orthopedic surgery providers. The report will show prescription graphs separated by type: opioids, buprenorphine, sedatives, and stimulants. Each type section will look like this one. Your prescription by month is shown, your prescribing by month is shown with the bar graph, and the pink line is that of the peers in your specialty group. The reports are also interactive. So if you'd like to see the patients and prescriptions that contributed to these graphs for your prescribing, you can click on the graph and view details. This is something new within the last year or so that they became interactive. We did get quite a few questions about them, so it's nice to have that extra added tool. The last section after the prescription sections will display potential at-risk factors for patients you prescribe to. Again, you can click and view patient and prescription details. There's no action required when you receive the Minnesota PMP prescriber report. However, we do encourage you to take advantage of this resource. It is a great tool to identify inconsistencies in your prescribing, which could be indicative of a breach of credentials or possible fraudulent written prescriptions. So it's good to take a look once a quarter. There's a feature that I mentioned earlier that entities within Minnesota have been able to utilize to expedite access to PMP data. Some clinics and health systems or pharmacy groups have used a service called Gateway to integrate a PMP report view into their electronic record system. When this feature is utilized, the health system works with their software product vendor to place a customizable icon in the EHR. When, in this case, Dr. Smith uses her credentials to access a patient's chart and clicks on the special link, instantly Dr. Smith's Minnesota PMP credentials, along with the necessary patient information, are sent to the Gateway Hub. The packet of information is sent, in this case, to the Minnesota PMP. It looks for an active PMP account for the provider, and then a current PMP report is generated based on the patient information that was sent. A PDF view is presented to Dr. Smith within seconds. The data itself does not get integrated into the EHR record. It's the access to the data with one click that gets integrated into the record, and that's what we call integration. Because the Gateway Hub is able to use the state-to-state connection technology already in place, healthcare systems can request access to other states and jurisdictions that Minnesota has agreements with. The ability to request other states is set up between administrators at the healthcare entity and the gateway team at the time of implementation. So we kind of are out of that. Items of note, searchers using the gateway must have an active Minnesota PMP account to successfully perform a search. Abbreviated searches are only able to be performed in the web portal. The full name from your EHR is sent with that one click. So if you have patients with hyphenated names or shortened names or nicknames, we usually recommend that you can still go into the web portal and perform those abbreviated searches. And there's no access to the integrated option for delegates. It's a on-demand access, so it kind of takes that middleman out of the formula, so those delegates aren't required to pre-produce those paper reports for the providers prior to seeing patients. So integration efforts began in 2016. Immediately, this process has had positive feedback from our account holders that had access to it. The technology brought searching patient history from about 3 to 5 minutes, I'd say, to only a few seconds. So why wouldn't everybody want to do this, right? Well, unfortunately, the issue is definitely cost. Bamboo Health, which created the gateway integration, charges each entity a startup cost and a per user licensing fee on an annual basis. So efforts were made beginning in August 2020 through grants that we received from federal government and collaboration with other state agencies. The Board of Pharmacy has been able to purchase that statewide license for integration. The statewide license waives the setup fee for Minnesota entities, and it covers the per provider fee at a discounted rate that we're paying with grant funds. So I want to provide just a tad bit more information for those that are not currently accessing PMP reports with one click. The Board of Pharmacy continues to secure funding through federal grants and support from other state agencies, and will continue to provide a statewide license for this functionality as long as we can. We will continue to support this. We believe that this functionality should be provided to every prescriber and pharmacist in Minnesota without the provider or health entity having to absorb the cost. If you or your administrative team would like information on how to enable this access, please go to our website, and we have a dedicated page that's titled Statewide Integration. There's information and a welcome kit that has tons of details regarding the process that your IT people would just love to pour all over. Now, decision makers only will access the Customer Connect portal link that's on that page to begin the process. There will be information and documents assigned sent immediately to that individual once they submit that. Depending on the previous work done by your EHR vendor, access could be as soon as 1 day, or there could be some custom programming required if your vendor has not yet prepared for this. There's a list of vendors on our website and their integration work statuses, so you can take a look and see if yours is on there. I'm going to wrap up today's session by pointing out a few of the Minnesota PMP resources that may assist you in accessing some of the information that we covered here today, and probably quite a bit more. First is the Minnesota PMP website. From the homepage, you're going to see a navigation list on the left side below the word home. The tab called Registration and Resources. This is the page where you're going to be able to access information dedicated for PMP patient history report searchers. So those that log into Aware and are looking for patient reports. An icon that reads Create a New PMP Aware Account will be listed first on that page, so anybody that needs a new account. And the page also includes how to create a new account, tip sheets, FAQs, and a full user guide for the Aware system that's super simple to use. You could click through the table of contents and like hyperlinks. Really easy to use. There's also resources within your Aware account. Within Aware, there's quick links on your dashboard. My dashboard is your landing page when you log into your account. We keep these up to date with new information or tools that may be helpful to you. This includes link to a treatment locator that has an up-to-date bed finder. I'm not sure if anybody out there uses the Fast Tracker. There's also a tab titled training. This tab has information regarding the NARCS Care report, how to interpret NARCS scores, and a link to the same user guide that's on our website. Our vendor has recently upgraded their help desk feature. Rather than calling or submitting a general ticket for help, they've created an interactive site for each individual product. So AWARE account holder help, NARCS Care report help, clearinghouse, and for data submitters, and gateway help for integration issues. On the PMP website, you can click the Contact Us page and you'll see a place to select for any issue that you're having. And these question and answers are available 24/7. The available answers may not solve your problem right away, but it will tell you that you need to submit a ticket because it's not available here, and it will get it to the right person quicker. So when you will be asked to log in to submit a ticket, but the response will come right back to you. And it really seems to be a good system for getting the correct information to the right person. Of course, you can always contact them by phone. Their phone number is clearly marked on the Contact Us page. I don't like to hide any phone numbers, so it's right there. And of course, there's no question we won't try to answer. So you can call us or email us. Typically, email is the best way. We find that if we miss your call, it's extremely difficult to get you busy people back on the phone. I think the individuals tasked with screening calls for busy providers are trained by like special ops. They simply will not patch me through without giving my birth date. Sometimes I just give them my birth date. And then I get somebody on the phone. But all questions sent are typically answered on the same day. The only time there would be a delay is if we're assessing who is the best person to answer. So here you can see our contact information, but of course it's on our website Contact Us page as well. And now I'm just going to say thank you for listening. And I may have time for questions, I'm not sure, but you know that I'll be back next month for Q&A.
No, we're going to capture a few questions right now, Shannon.
Great.
Okay, one question, and I'm going to need to talk to you offline about mine because I have no idea. I don't even have an account if I go to the website yet. I can pull it open, like it's in my Epic. So I can pull it open in the Epic, and there was another question in there about that. It pulls in through the Epic. Is that something you then still have to go on the website to like do the delegate auditing? All
Yes, there's always going to be a need for your AWARE web portal account. And if I'll give you this hint. If you're able to successfully submit a request through Epic, your account is active. If it stops, your account's inactive and you miss.
I'm going to have to help her with this.
No.
Being an IT kind of guy.
No, I literally just tried to log in because it's in through CentraCare now, and I literally do not have an account like through CentraCare. I tried to request my reset of my password, and it's not connected to that email that my Epic is. So that's weird. We'll talk.
That's a great example though, because we get that question quite a bit. Somebody hasn't logged into their account in some time. They've changed employers, and they don't have access to their previous email account to reset their password. It's super common. What you want to do is just send an email to our program, and what we do need to do is verify just a couple points of credential to make sure that we're talking to the account holder. And we verify date of birth and last four of social. Because again, we know that your administrative staff knows everything about you. So we had to try and think of something that you would know. And we figured last four of social is it. And that's the only thing that we use that for. But we will ask you to provide that to assure us that it's you. Because when we change your email, we're changing your username. And that is just handing access to somebody. So just send us an email and we will get you in right away.
So Shannon, I got one of these alerts last week, and I looked all over it, and I'm pretty sure it's because one of my Suboxone patients, someone else put them on maybe a benzo or something. There's nothing on that sheet, unless I'm mistaken, where I can click and go right to my account. Is that correct? I mean, when I got that, I have to go out and go to my PMP log in?
So the email doesn't have a link to log into an account.
That's what I'm wondering. 'Cause
Let me
I
take that back as, I'm going to take that as feedback and I'll address that.
Okay.
I
'Cause I
haven't tested out a lot of those emails. I know I looked at them, but I'll double check on that and I'll get back to you, and I'll be able to follow up next time I talk to you guys too.
Okay, because it seems like it would be a simple thing if that link was on there. I'm already logged in technically through Epic, so I should be able to go right to that, but I couldn't find something that did that. Maybe I'm confused, which is possible.
My IT help now,
Yeah.
apparently.
Well, I'm going to tell you, when you're logged in through Epic, that is for one thing, and that is for sending your credentials to search for a patient. If there's a link in your email, you're still going to need to log into that web portal account, because that's actually, if it's through your email, you're not going into your web portal account through your EHR. You as a provider are logging in to review those alerts.
Okay.
And the alerts are in no way, the alerts are not shared with are not going to be available, so to speak, in Epic. They're available only, number one, to you. And number two, they're available to somebody to see as a flag if they actually are performing a search of that patient.
Yeah, because I've never seen one of these alerts through Epic.
You're not going to see it in Epic, only if you produce a report and you'll see a flag in the report.
Okay.
And then if you log into your PMP account, you'll see your dashboard with a list of any patients that that you prescribed for that have an alert related to those prescriptions.
So then there's another question about, pharmacies reporting this data, and I've run into this. Sometimes they seem to be reporting it to the PMP, like when they get my script, not yet when they give it to the patient. So occasionally, like, the patient will go there, it's way too expensive, or there's an issue, and they won't actually pick up the prescription, yet it says on the PMP that it was filled. And when we're talking Suboxone scripts, this is a big deal. So is there like a way that pharmacies are supposed to report this, or how does that work?
Well, that's a different, and it's something that's changing, I will say. It's the difference between date filled and date sold. And now date filled has always been a required field when reporting. And there's differences between how pharmacies interpret what date filled means. Pharmacies can say without a doubt, when the pharmacist authorizes and fills that prescription and puts it on the shelf for the patient to pick up, that they may interpret that as date filled and it's reported to the PMP. Now, if the patient does not come in and pick it up after whatever their policy is, I think CVS has 2 weeks. I only know that because they're my pharmacy. It'll sit on the shelf for 2 weeks, and if it's returned to stock, they do need to delete or void that prescription from the PMP. Not super helpful for providers that are looking at that prescription for 2 weeks that hasn't been into the hands of the patient. Now, there are pharmacies that have more sophisticated prescription reporting capabilities, such as point of sale, where they can submit date filled, and then they can submit date sold when the patient actually picks it up. Now, currently, we collect both. We collect date filled and we collect date sold. But because of the way that the data is structured, date sold, because it's something new, has not yet been able to be presented through the gateway. So it's presented in a NarxCare report if you log into your PMP account. And we are currently, nationally, we are going through an update to the standards for reporting that will include date sold.
Yeah.
And that will enable it to transfer through the gateway, through the integrated system. But I can't say it's going to be next week.
Okay, no, that's helpful.
I have kind of an interesting question because it's, I think it's interesting that the pharmacies they do the date and such, that they sold it, that they filled it, and all these things. There are actually government agencies that will come across patients with these medications, and they will take them away and destroy them. And that isn't reported to the PMP, which is interesting because then when we need to fill these medications when they get out of jail, we are unable to because they're supposed to have had medication still. And it's an interesting kind of a glitch in the system where a county-run or state-run facility can find a patient, arrest them, destroy their meds if they don't have their prescription on their person, but they don't have to report that those are destroyed. Just wondering if you have a thought regarding that.
The PMP the technology that we have with AWARE, it does have the ability to intake notes, intake comments, things like that would allow that. But our statute in Minnesota allows us our responsibility according to statute, and that's what we have to follow at this point, is we collect and display prescriptions that were dispensed. So our hands are tied as far as putting any additional notes in there, comments, anything like that. But I agree that that's valid information. However, we have to continue to look at the PMP as this is a starting point of an investigative tool.
Right.
So if there's question about it, if the patient says something, if they just got out of jail, a call to continue investigating what actually happened. Did this get dispensed? Yes, it did. Well, they went into jail at this day, and there's a responsibility to use this as an investigative tool until the point that we ever would get a legislative change that would allow us to make this into a fully functional, database that contained a full picture of every patient.
So I think some of the problem with this and not being able to get it filled next time, because obviously the PMP isn't what's saying you can't fill this, we should have more meds, is the insurers see that, or how much interaction do you have with those insurers? Because it seems like they know how much was filled on which date.
None. They are not allowed to have access to our data.
Yeah, it's only by what they get as it reported medication that was paid for.
Right. So that's kind of where, even if the PMP could be updated, it wouldn't change the refusal to be filled because that's coming from the state.
Yeah.
Or with the insurers. Okay. So as far as like the ADDM machines, so the machines that just the automated dispense machines, you mentioned nursing homes, jails are another one that sometimes do have the controlled substances on board. Isn't it though that a lot of the meds that fill those machines have come from the pharmacy to stock those machines? If we're talking about the CLIA waivered or whatever they're called, dispensing, and so if that's the case where like a nursing home is getting a prescription filled for a patient, like their pharmacy supplier to fill the machine, does the pharmacy that's giving that to the nursing home, do they not report that then because it was dispensed from that pharmacy?
I'm going to have Brock, are you on the line? I think my director is on the line. And we just had an instance about something like this with an Instamed machine in an emergency department. And I believe it was based on who was stocking the machine was responsible for reporting. But I can get more information on that. And you're talking specifically in jails?
Well, jails or nursing homes. Because, in order to stock that machine, there had to be a prescription from a provider to have them even on that med. Mm-hmm. But how they dispense them in those facilities comes from a dispensing machine, if you will. So it's... So that was more the question is would that not be reported, or because it's getting sent through a machine, maybe they don't have to report them. So that was just, it's more of a nuanced question.
I'm not sure the answer to that specifically, but I will do my best to get a better response to that and find out exactly what is required.
Sure. Okay. And then there was a question about like the gateway, if gateway is only state data, or if you can somehow add like Wisconsin to the gateway data that's in the EHR.
You can add other states. That's set up between your entity administrator and the gateway contact, which would be, you could reach out through the link on our contact us page. However, I'm going to say at this time, Wisconsin does not approve access through the gateway. They have something in their statute that does not allow sharing through a third-party entity. It's very complicated, and they are working on it. We've been working with them for probably 2 years on trying to get that some way around that. But as of right now, there will not be any Wisconsin data through the gateway.
Gotcha.
Shannon, can you tell me, is there some specific reason, we only have a minute or so left, any specific reason it only goes back 12 months? What was the reason for that statute?
Data privacy for patients, that their previous prescriptions aren't used to, those fall off and they're looked at as a new patient. And really, there's a group in the legislature that's extremely protective of patient privacy, and they advocate very strong. So we request additional data retention. I mean, that's always something that we're trying to fight for, but I don't know how successful we'll ever be with that, but we'll continue to try. There's just a strong presence.
Okay, I have one final question. In terms of, Minnesota, nice. Hi, Dana. Hope you're
You're funny.
The ability to actually, and I know that back when you talked for us the last time, and the time before that even, talked about how the PMP is not supposed to be used for data collection and report, like for researchy purposes in any way. Has there been any new recent talk about integration? And I'm referring mostly to like the OPIP project, the opioid prescribing project, because the stuff that you have on your provider reports does mirror exactly what we get on our provider report cards through OPIP. Yet yours is more comprehensive because it's all payers, not just state programs. Mm-hmm. Is there any talk to like share information or to work together?
Always.
Because like it's funding too, like why are we paying, I think it's just better use of funds, and just curious if that is something that might be coming down the pipeline.
We talk about it all the time, and it's nice to hear other advocates. If there's ever a time that we need somebody else to come and talk with us, I'm going to call on you guys. But yes, we just can't share our data with anybody. It's just that simple. But we know that we have a nice data set that would do, good for certain groups and supplement a lot of information. But the PMP, the intent of the PMP was set the way it is. And I personally don't foresee any changes happening, but I will continue to try and do what we can do.
In my mind, Shannon, the issue I would have is there are cash clinics. And so those do not run through, and those cash clinics can be pumping out any kind of controlled substances, and it's not run through, it potentially isn't run through MA or a state program, right? So they take only people with insurance and not MA or not other things.
Yeah. So we're just missing a lot of the outliers.
Yeah.
Yeah, I think if realistically, those clinics are required to be reporting to the PMP, number one.
But not to the OPIP. I think that's what we're saying, is you're missing a lot of the data from the OPIP project and the report cards. You're getting it all. The state is not.
Yeah.
Yeah, and we can't even look at the data to determine what those patterns are. However, if you see something like that, I mean, you can, the probably to report that to the board related to the prescriber that's associated with it would be a good way to start, because the board, if they have an open complaint investigation, they can access the data. And that is really enabling the board to have an open complaint is the way to get the data into the disciplinary hands.
Right.
All right. One more question that came through. Will the PMP data ever be made accessible to the medical review officers who are trying to validate drug test results?
I can take that back, but in what sense? Is this for just in a private clinic or?
No, so that was my question. So medical review officers don't technically have a relationship with the patient. They're hired by somebody else to review drug test results. And if something is positive, you need to, so say it's an opiate or something like that, you need to confirm that that was actually prescribed for the patient within a certain time frame.
Okay.
So now the way you have to do it is just lots of detective work versus a couple clicks into the PMP and you'd have your answer.
Yeah, no.
But the person is not prescribing for it. You're confirming that it was prescribed.
So the provider that sent you the drug test, they are
Usually an employer.
An employer? No, I doubt it.
Okay, thanks.
Yeah, sorry.
Great question.
Oh, you know what you can do? You can have the patient be required to submit a third-party request form for their employment. That's it. I mean, not many people do that, but you can do that. It's on our website.
What's the turnaround on that?
Same day usually.
Oh, okay. Okay, thanks. Good to know.
Miranda is awesome. She's our admin person, so coordinator.
All right. Well, we better let you go, Shannon. We went a little bit over because the questions just kept coming, but next time we'll just continue to pester you.
Okay, I'll be ready. Maybe I'll bring Brock on too, just in case he needs to help me with stuff.